allowing me to start the session of brachytherapy, multidisciplinary management of cervical cancer, focus on CRD adaptive brachytherapy. Cervical cancer, the state of the art. Our first speaker will be Professor Helmut Tower, the director of the oncology unit and professor of obstetric and oncology at Shamsu University, and he will address cervical cancer prevention and screening as a challenge. Go ahead, first.
بسم الله الرحمن الرحيم. اولا بشكر اللجنه المنظمه المؤتمر، بشكر دكتور باسل ودكتور ايهاب، وبشكر كل زمايلنا في اسم الكلينيكال اونكولوجي. My talk today is about cervical cancer prevention. The problem cervical cancer is the third most common cancer worldwide. About 500,000 new cases identified each year. At least 2,100 women die of cervical cancer each year. One woman dies of cervical cancer every 2 minutes, making it one of the greatest threats to the woman health. Cervical cancer is easily accessible to early diagnosis and treatment, which can drastically reduce the mortality. More importantly, to a large extent, cervical cancer is preventable disease. No woman should die from a deadly disease that both preventable and curable. سريعا نتكلم على البريفنشن بتاع السيرفايكال كانسر. عندنا في البرايمري بريفنشن، وعندنا secondary prevention, third prevention. First prevention mainly through vaccination against human papillomavirus. Second prevention through screening and treatment of pre-cancer lesion in women. It's cost-effective way to prevent cervical cancer. The third, through diagnosis and treatment of invasive cervical cancer. The main cause of cervical cancer is human papillomavirus. Human papillomavirus تقريبا مسؤول عن 5% من كل الهيومن كانسرز. هو بيأفكت الميلز والفيميلز. هو المسؤول الرئيسي عن السيرفايكال كانسر. Human papillomavirus is a group of viruses that are extremely common worldwide. There are more than 200 types of human papillomavirus, of which at least 14 are cancer-causing, also known as high-risk type. Two human papillomavirus types, 16 and 18, causes 70% of cervical cancer and pre-cancerous cervical lesions. There is also evidence linking human papillomavirus to other cancers like cancer of anus, vulva, vagina, penis, and oropharynx. As we know طبعا الهيومن papillomavirus بيأفكت stratified squamous epithelium through the skin أو الميكوزا. Comprehensive cervical cancer control includes primary prevention through vaccination against human papillomavirus, secondary prevention, screening and treatment of pre-cancerous lesions, tertiary prevention through diagnosis and treatment of invasive cervical cancer, and palliative care. Human papillomavirus can cause several types of cancer. Number one, cervical cancer, vaginal cancer, anal cancer, oral cancer, penile cancer, vulvar cancer, but human papillomavirus is the main causing factor of cervical cancer. It affects males and females. As we said before, penile cancer, recurrent respiratory papillomatosis, oropharyngeal cancer, genital warts, cervical cancer, cervical dysplasia, vulvar and vaginal cancer. Famous victims of human papillomavirus: Michael Douglas died, American actor, died from oropharyngeal cancer due to human papillomavirus infection. Jane Jody English television personality, Erin Andrews, and Eva Perón. All of them died from cancer due to human papillomavirus infection. This timetable of selected achievement in human papillomavirus prevention. The history اكتشفوا ازاي طبعا الباب سمير اتعمل سنه 1940 41 لجورج باب نيكولا اللي هو امريكان فيزيشن انفنت الباب سمير. بعد كده سنه 74 ابتدى هيرالد زور هاوسن hypothesized unknown virus in genital warts may cause cervical cancer. اكتشف زي بارتيكل موجوده في الورتس قد تكون هي المسبب الرئيسي للسيرفايكال كانسر. سنه 1980 الى 1984 هيومن بابيلوما فيروس 611 اللي هم بيكوز بناين warts 16 and 18 was discovered. في 1992 هيومن بابيلوما فيروس ميجر كابسيد بروتين 1 self assembles as immunogenic virus like particle عشان الفاكسين. 2003 ابتدى يتكلموا على الهيومن بابيلوما فيروس دي ان اي تيستنج از سكريننج فور سيرفايكال كانسر في الفيميلز اللي هم 30 years or more. 2006 كان الفيرست ديسكفري بتاع كوادريفالنت هيومن بابيلوما فيروس. سنة 2008 هيرالد زور طبعا خد جائزة نوبل على انه اكتشف ان الهيومن بابيلوما فيروس هو السبب الرئيسي فور سيرفايكال كانسر. عشان كده بنقول ان سيرفايكال كانسر ده preventable disease and curable disease. You can prevent the disease through vaccination. وفي لونج تايم انترفال ما بين البري كانسر ستيج والكانسر تقريبا من حوالي 5 سنين الى 10 سنين عشان السي اي ال يتحول الى انفيزيف كانسر. عشان كده عندي تايم ان انا اقدر اعمل باب سمير، اعمل الهيومن بابيلوما فيروس دي ان اي تيستنج وي كان اريديكيت الكانسر سيلز في البري انفيزيف ستيج. سنة 2014 الاف دي ابروفز فيرست هيومن بابيلوما دي ان اي تيست فور برايمري سيرفايكال كانسر. احنا كنا بنعتمد على الباب سمير قبل كده كل 3 سنين. ريسنت طبعا دخلنا في التيست بتاع الهيومن بابيلوما فيروس ديتكشن اوف هاي ريسك جروب لايك 16 and 18. It is well documented that nearly 90% of incident human papillomavirus infection are cleared within a period of 2 years from acquisition of infection and persist only in about 10% of women. It is debatable whether the virus is completely cleared or it remains latent in basal cells with potential for reactivation in some cases. Almost حوالي 90% من الهيومن بابيلوما فيروس في خلال سنه الى سنتين بيحصل له كليرنس خصوصا في اليونج ايج. معظم الوقت اللي بيبقى فيه acquired human papilloma virus after starting sexual activity after the age of 18 years. The natural history of cancer cervix, normal cervix when exposed to human papilloma virus, about 60% regress within 2 to 3 years. بعد كده البريزيستنس حوالي 10%. محتاج كمان كو فاكتور عشان يعمل لي كارسينوما لايك سموكينج، اميون سبريشن، فيري لو جريد سكوماس انترابيسيال ليجن، اتيبيا CIN1. About 15% progress within 3 to 4 years. The high grade squamous intraepithelial lesion اللي بنقول عليها CIN2 CIN3 او كارسينوما انسايتو. 30 to 70% progress within 10 years to invasive cancer. ده الاستراكشر بتاع الهيومن بابيلوما فيروس. عندي هو عباره عن دي ان اي فيروس وحواليه كبسه. الكبسه ده اللي خدوا منه البارتكلز اللي هو L1 و L2، خدوا من L1 الفيروس لايك بارتكل وعملوا منه الهيومن بابيلوما فيروس فاكسين. عشان كده الفاكسين ده مش انفكشوس لانه مفيش دي ان اي بتاع الفيروس. ومجرد ان الفاكسين بيكريت انتي بودي عشان تمنع الهيومن بابيلوما فيروس انفكشن. Human papilloma virus is a DNA surrounded by a protein infused capsid. The capsid acts to surround and protect genetic materials. It helps to bind particular cells that the virus need to infect. الهيومن بابيلوما فيروس بنقسمهم الى اللو ريسك جروب والهاي ريسك جروب. الهاي ريسك جروب مين؟ تايب 16 وتايب 18 دول بيعملوا حوالي 70% تقريبا من الكانسر سيلز. هم في حوالي 14 نوع من الهيومن بابيلوما فيروس اونكوجينيك. الاثنين 16 و 18 بيعملوا حوالي 70%. الفيروس دلوقتي الفاكسين اللي هو النونا فيروس بيغطي 9 انواع من الهيومن بابيلوما فيروس. عشان كده نقدر نعمل بريفنشن ثرو الفاكسينيشن about 90% of cervical cancer. 90% of ايه congenital births بيسببها الهيومن بابيلوما فيروس 6 و11. The life cycle of human papillomavirus, as I said before, it only affects the stratified squamous epithelium. الفيروس بيدخل الستراتيفايد سكومس ابيثيليوم ثرو مايكرو ابريشن، لازم يحتاج دايركت كونتاكت، وده موست كومنلي بيحصل عن طريق السكشوال كونتاكت. اول ما الفيروس بيوصل للبيزمنت برين، بعد كده بيفكت البيزل لاير، بعد كده يحصل له بروليفيشن، وبعد كده طبعا يحصل ديسكوميشن للفيروس بعد ما يكون بقى انتجريتد في الدي ان اي بتاع البيزل والبارا بيزل والانترميديت سيل لاير. الروت اوف ترانسميشن في هيومن بابيلوما فيروس هو طبعا the most common route of transmission through sexual transmission. other route of transmission vertical transmission من الام للبيبي اثناء الدليفري، ساعات بيعمل لارنجال بابيلوماتوزس، ساعات بيبقى hospital transmission through an instrument by sharing objects through blood transfusion query. But the main route of transmission is sexual transmission. How to prevent الكانسر سيرفيس؟ عندنا برايفت بريفنشن. ذا بيست ان انا امنع الكانسر سيرفيس عن طريق ان انا امنع الهيومن بابيلوما فيروس انفكشن قبل الستارتنج بتاع السكشوال اكتيفيتي. عشان كده الروتين المفروض عند سن 11 ل 12 سنه ندي الهيومن بابيلوما فيروس فاكسين. Education to reduce high risk sexual behavior, measures to reduce and avoid exposure to human papillomavirus and other sexually transmitted diseases, avoiding and minimizing other risk factors like early marriage, early childbearing, and smoking. Human papillomavirus vaccine عندنا prophylactic vaccine that create antibodies against capsid L1 and L2. بنتكلم دلوقتي على therapeutic vaccine في التريتمنت بتاع CIN2 والCIN3 through creation of antibodies to treat CIN2 أو 3 through creation of antibodies against E6 and E7. E6 و E7 دول الفيروس بيطلع about 7 types of protein من أول E1 لحد E7. E6 وال E7 2 main protein بيطلعهم الفيروس. E6 بيعمل disruption للB53 والE7 بيعمل disruption للريتروبلاستوما انتيجين. البي 53 زي ما انتم عارفين ده تيومر سبريسور جين، والريتروبلاستوما بروتين برضو ده تيومر سبريسور جين. فده الميكانيزم اوف اكشن ازاي الفيروس بيحول السيل من نورمال سيل الى كانسر السيل. بالنسبه للفاكسينيشن كان عندنا البايفالنت فاكسين اللي هو بيغطي 16 و18 اللي هم المسؤولين عن 70% of cervical cancer، ده انفنتد سنه 2009. بعد كده طلع الكوادري فيلنت فاكسين اللي هو الجاردزيل بتاع شركه ميرك، ده بيغطي تايب 6 و11 16 18. 6 و11 اللي هم بيعملوا الورتس فالفر وفاجينال وسيرفايكال وورتس اللي هو البناين تيومر. 6 و 16 18 اللي هو كانسر سيرفكس. بعد كده طلع النونا فيلنت فاكسين جاردزيل 9، وده موجود بس في اليونايتد ستيتس اوف امريكا. ده بيغطي 9 انواع من الهيومن بابيلوما فيروس، بيغطي 6 و11 اللي هم البناين، وبعد كده بيغطي 7 انواع من الهيومن بابيلوما فيروس اللي هم تقريبا مسؤولين عن 90% من الكانسر سيرفكس. قبل كده 16 و18 بيعملوا حوالي 70%، لما اضافوا حوالي 5 كمان غطوا 90% من الكانسر سيرفكس. عشان كده كان الهيومن بابيلوما فيروس ما بيديش فول بروتكشن اجينست كانسر سيرفكس. بعد العيانه ما بتاخد الفاكسينيشن برضه ستيل وي نيد ان احنا نعمل السيرفايكال سيتولوجي كل 3 سنين. ده الجاردزيل فاكسين 9 و4. ده الفاكسينيشن فاكسين to protect you against cancer. Human papillomavirus cancers are preventable cancer. We don't want to lose you to this disease. باخد الفاكسين فين؟ بيتاخد يا اما في انتراماسكولار، بيتاخد في الدلتويد ماسل، او بيتاخد في الثاي. ما بيتاخدش سبكوتينيوس، ما بيتاخدش انترافينوس. الميكانيزم اوف اكشن اوف فاكسين، الفاكسين طبعا الناتشرال انفكشن بتاع الهيومن بابيلوما فيروس، هو الهيومن بابيلوما فيروس بينفكت الاستراتيفايد سكومس ابسيليوم، ما بيعملش فيريميا. عشان كده تقريبا 50% من الناس اللي جالها انفكشن بالهيومن بابيلوما فيروس ما عندهمش ديتكتبل سيرم انتي بودي، و50% عندهم لو ليفل من الانتي بوديز ما بتديش بروتكشن. الفاكسين بيأكت ثرو كرييشن اوف انتي بوديز، الانتي بوديز تمنع الهيومن بابيلوما فيروس انفكشن. الريكومنديشن الفاكسين بيتاخد طبعا قبل كده كان قالوا من 9 سنين الى 26 سنه، بعد كده تقريبا بقينا من عند ممكن ناخد الفاكسين من 9 سنين الى سن 45 سنه. بناخد كام جرعه؟ لو احنا قبل 15 سنه بناخد 2 دوزز، باخد 0 وبعد كده اخد من كده من 6 ل 12. بعد 15 سنه باخد 3 دوزز، باخد فيرست دوز 0 وبعد كده باخد من شهر لشهرين وبعد كده اخد من 6 شهور الى سنه. ده السكيدجول بتاع الهيومن بابيلوما فيروس فاكسينيشنز. ريسنتلي طبعا ابتدوا يتكلموا او تطلع دراسات عن السنجل دوز فاكسينيشنز، بيقولوا ان السنجل دوز فاكسينيشنز از افكتيف لايك التو دوزز والثري دوزز. عشان كده ريكومنديشن ان يبقى انتجريتد في الروتين فاكسينيشن بروجرام عند سن 11 ل 12 سنه الست تاخد سنجل شوت من الهيومن بابيلوما فيروس فاكسين. ده شورت فيديو كده بيشرح الباب سمير. ده الهيومن بابيلوما فيروس بيبقى انتجريتد في البيزل سيل. ده التكنيك اوف باب سمير. بعد ما اتكلمنا على البرايمري بريفنشن احنا قلنا مينلي ثرو فاكسينيشنز. لو احنا ما خدناش الفاكسينيشن عندنا secondary prevention of cancer cervix، ان اعمل detection of secondary prevention. الباب سمير بيبتدي السكيدول بعد ستارتنج السكشوال اكتيفيتي بثلاث سنين، تقول له من سن 21 سنه الى 29 سنه بيتعمل باب سمير كل ثلاث سنين مره. من سن 30 سنه الى 65 سنه يا اما اعمل باب سمير كل ثلاث سنين، يا اما اعمل الهيومن بابيلوما فيروس تيستنج كل 5 سنين وديتكت الهاي ريسك جروب، يا اما هعمل حاجه اسمها كو تيست بعمل الاثنين مع بعض، الباب سمير مع 10 سنين كان الباب تيست نيجاتيف والهيومن بابيلوما فيروس ممكن استوب ان انا اعمل سكريننج للكانسر سيرفيس عند سن 65 سنه. ده السيستم كود كلاسيفيكيشن اوف فاكسين عندي نورمال سيلز. بعد كده عندي التيبيكال سكور سيل عندي لو جريد سكور سيل الهاي جريد سكور سيل لو كان بيزك كانسر ده النورمال سيلز لو كان سيليا كان كانسر ده شكل السيل بتاع النورمال سيلز شكل لو جريد سكور سيل بتاع ال1 والسي اي ده النورمال سيلز وعندي سيلز بتاع الابلكيشن 3 to 5% اسيتيك اسيد اسيد وايد ميديم abnormal area ده النورمال سيلز ده بعد الابلكيشن اوف اسيتيك اسيد. السيستم بيتكلم على كان في سيليا abnormal هو السيلز تيبيكال هو السيلز لو جريد 5 جريد سكور سيل كارسينوما ينادي بالتالي النورمال كانسر ده الهاي
Thank you, Professor. Just I want to ask about the cost of the vaccine, which is available in Egypt or not, and what's the impact of this vaccine for defensiveness of cancer cells? As I saw in your slide, it's something to 15 years or maybe more.
Yeah. Unfortunately طبعا it is an expensive vaccine فمش دلوقتي مش قادرين ندخله في الروتين فاكسينيشنز. تقريبا الجرعه كانت بحوالي 700 دلوقتي الوان دوز تقريبا بحوالي 1000 جنيه. ده بالنسبه للكوست بتاع الفاكسينيشن. Yes. It's available. افيلبل الكوادري فيرنت فاكسين اللي هو بيغطي 6 و11 و16 و18. النونا ده مش متوفر عندنا هنا. هو للاسف طبعا زي ما انت عارف احنا الكانسر سيرفكس عندنا هنا معظم الحالات اللي بنشوفها بتبقى حاجات ادفانسد في مصر عندنا. ابرود لا طبعا، يعني هم عندهم الانسس بتاع كانسر سيرفكس بعد من قبل الهيومن بابيلوما فيروس فيري لو، نتيجه ان هم ملتزمين بالسيتولوجي اللي بيتعمل كل 3 سنين.
سويدش ناشونال ترايل هي بعد 20 سنه من الفاكسينيشن حصل مارفلس اليمينيشن للسيرفايكال كانسر في السويد، وبعدين لسه بريتش جورنال لسه مشهوره من شهرين ثلاثه ان السيرفايكال كانسر انسنس قلت حوالي 70%. حتى الكلام دلوقتي بيقولوا بتوع منين بتقولوا 90% و70% بس اللي حصل فاكسينيشن، كلام على تترافيرنت فيرنت، انما ايفيدنس بيز ليفل 1 وعمل مارفلس اليمينيشن للسيرفايكال كانسر انسنس في الدول اللي فيها هاي بريفالنس سيرفايكال كانسر.
وعندنا دول عربيه ابتدت تدخلوا السعوديه، المغرب، تونس، ابتدوا يعملوا كروتين فاكسينيشن، انما للاسف لسه في مصر عندنا. نعم، هو 700 جنيه مش كتير بالنسبه لك يا دكتور احمد. ده اللي احنا نفسنا نعمله، وطبعا نفسي الدكتور باسل يساعدنا في القصه ديت ان احنا ندخله كروتين فاكسينيشنز لكل الطلبه يا دكتور باسل. يعني احنا نفسنا طبعا يعني حضرتك تساعدنا يبقى ده جزء من روتين فاكسينيشن عند 11 12 سنه. اي
شو يا دكتور حلمي، يعني هو 900 هي الكوست دلوقتي في مصر بالظبط الجرعه ب 937 جنيه، كانت 750 جنيه من كام شهر، 937 دلوقتي، ومقارنه بالدول اللي حوالينا فيعتبر رخيص، سعره رخيص مش غالي، يعني 937 بتتكلم بالدولار مش حاجه خالص. وهو فعليا اعتقد ان الدوله كانت بلاننج ان هو يخش في البرنامج اللي دخل في ليبيا وفي المغرب حتى في دول الخليج بس، ولكن جال الكورونا وبعد كده حرب روسيا واوكرانيا وبعد كده اللي بيحصل حاليا، يعني كان بس اعتقد كان معانا حد من مكتب المبادره الرئاسيه تقدر تقول لنا في امل في الفتره الجايه.
وهو دايما كمان يا دكتور باسل the best prevention is primary prevention، يعني احسن حاجه تبقى بروتكتيف الفاكسين انه يتاخد قبل الستارتنج بتاع السكشوال اكتيفيتيز، او برضه هيتاخد بعد ستارتنج سكشوال اكتيفيتيز، او العيانه اللي اوريدي انفكتد بالهيومن بابيلوما فيروس برضه هتاخد، لان هو ممكن عيانه يبقى عندها تايب وهي تبقى انفكتد باذر تايبس، ولكن ذا بيست تايب ان انت تعمل فاكسينيشن قبل الستارتنج بتاع السكشوال اكتيفيتيز.
هو الفكره ان دلوقتي من الفيجن بتاعت المبادره حاجه دلوقتي في ongoing مبادره presidential initiative للايرلي detection and treatment of cervix و other three disease areas، فمن البرايمري اوبجيكتيف بتاعها ان elimination of cancer cervix by 2030. يعني الفيجن بتاعت مصر هي ان احنا eliminate السيرفكس، فاعتقد ان هو بس لما اتعمل داتا لا ان هي statistically we have a lot of children، فبالتالي it was very high budget but we are working on ان الفاكسين ات بوينت اكيد هيخشوا في الناشونال فاكسينيشن.
الفاكسينيشن والباب سمير احنا للاسف الماجورتي ما بيعملوش حاجه اسمها باب سمير، ما بيسمعوش عنها، فده مهم جدا ان احنا كل 3 سنين نعمل الباب سمير.
هو دلوقتي في اتش بي في فيروس انفكشن، اتش بي في فيروس تيستنج اوريدي بيتعمل بس فور ذا هاي ريسك از بايلوت ستادي، وليتر هيبقى يعني فور
يعني نتمنى شكرا.
انا ليا سؤال
العيان بص 01 يس قبل 15 سنه بناخد 2 دوزز 0 وبعد كده من شهر ل6 شهور.
انا ليا سؤال بقى هو
من 6 شهور لسنه. تمام.
يعني how much حضرتك بتريكومند الفاكسينيشن للبويز؟ لان احنا سينس الكالتشر اوريدي، يعني انا لما حد بيسالني بتلاقي الكالتشر اصلا ان احنا طب نفاكسينيت البنات. طب
هو لو انا عملت فاكسينيشن للبنات هقلل الترانسميشن للاولاد، هقلل الترانسميشن في الكوميونتي، فانا وانس ان البنات حضرتك كلهم خدوا الفاكسينيشنز طبيعي ان انا
لان انا عارفه ان في ستادي
هقلل، ولكن يس هو ريكومندد للبويز اند جيرلز. الاثنين، لانه بيعمل برضه جزء مسؤول عن جزء من البينايل كانسر، من الانال كانسر، الاوروفارينجال كانسر، مش الماجورتي طبعا، ولكن بالنسبه للفيميل هو اولموست 100% من الكانسر سيرفكس سبب الهيومن بابيلوما فيروس. اولموست يعني تقريبا حضرتك يعني هو فهو حضرتك بس لو فكر
بدات تبقى اوير فبدات تسال، فاحنا وي نو ان البويز شود بي فاكسينيتد مع او the guidelines، بس بقى احنا كهنا بنريكومند يعني
حضرتك بس اعملوا لنا فاكسينيشن للبنات. وبعد كده
هو mainly البنات عشان دي بتقدر تدوس على كانسر الجينيتال وولز، فدي فيري كومن بروبلم في البنات. الولاد طبعا عندهم هاي انسس اتش بي في بس ما فيش سمير ولا في اي حاجه بتديتكت، فما بتعرفش لما الراجل يجي له جينيتال وولز بتبقى مزعجه جدا ليه والبارتنر، بنشوفها كتير بقى، فبيجي لي بعد ما يتعالج عشان ياخد الفاكسين. بس حتى انا بقول كل البنات كان عندي سيريز من اطول السيريز في مصر فور فاكسينيشن، يمكن 95% منهم جاي فيميلز، بس عندي رجاله واولاد وستات بيجوا يطعموا اولادهم، انما الولاد هيبقى مني فور بروتكشن البنات من الجينيتال ووردز والكانسر، واحنا الرجاله انانيين بطبعهم فمفيش حد عشان يحمي مراته، حتى لو جات له الراجل جينيتال ووردز او اوروفرنجيال كانسر بقى والكلام ده، بس يعني ده جروب سوري يعني، فالبنات مين اللي هو الاساسي.
هو كمان للاسف في الفتره ليتلي ابتدينا نشوف الوردز بعد الليزر هير ريموفال، ودي مشكله كبيره جدا. انتوا عارفين عندنا يعني الماجورتي من البنات بيروحوا للدكاتره بتوع الدرماتولوجي، ما اعرفش هم بيستخدموا ايه بالظبط، بس ابتدينا نشوف حالات ووردز بعد، تلاقي واحده صغيره لسه وما فيش اي نوع من السكشوال اكتيفيتيز بيبقى عندها ووردز، فابتدوا بقى الموضوع الليزر ده، الحاجات الابريجن اللي بتحصل عن طريق الليزر بتبقى طبعا كونتامينيتد، فدي مشكله برضو كبيره عندنا.
Thank you so much, Dr. Hilmi. For the sake of time, we have lots of questions with screening with vaccine. However, for the sake of time, thank you so much for the presentation. And we will move now to Dr. Dina Salman, a lecturer of pathology at James University, and the topic will be important facts regarding the pathology of cervical cancer.
Okay, good evening, everyone. This is Dina Samain. I will be with you today through the pathology talk on the cervical carcinoma. So to begin with, let's see what's the problem. Now we have actually the fourth most common frequent cancer of women, the cervical cancer, and it's actually constituting like most of the cases in the low and the middle income countries. But fortunately for the USA and some European countries, the incidence has dramatically dropped thanks to the incorporation of the cervical smears, as Dr. Hilmi just mentioned, which they used for screening, whether using the pap smear testing or the having material for the HPV molecular testing. Okay, and thanks again to the HPV vaccination that we've been just discussing. Okay, and now let me take you through a quick journey into a pathology lab where the story actually begins. We meet the cervix in one of three forms or one of three encounters, either a pap smear or a small excisional biopsy or a bigger resection specimen. Okay, when we receive actually pap smears, we report them in the form of the Bethesda reporting system, and the Bethesda reporting system is one of the following. It's either a NILM, and by NILM I mean we have an infection or a reactive change, or epithelial abnormality, including squamous cell carcinomas, adenocarcinomas, and their precursors, or to a lesser extent, some other malignancies. And when we receive from you tissue specimens, whether biopsies or resection specimens, we report them in the form of the CAP cancer protocol, the checklist for the College of American Pathologists. الحقيقة يعني we consider this as the messenger or the letter from me, the pathologist, to you, the oncologist. So through this messenger or through this letter, what does an oncologist expect from me? And what am I be able to deliver or to offer as a pathologist. Okay, let me take you through a quick resume into this checklist. Actually, through the CAP cancer protocol, firstly, I can provide you with further description about the specimen, the nature of the specimen, and this is according to what the respectable oncosurgeon has actually done. Okay, one more thing, I am supposed to report the tumor site. In case of small excisional biopsies, I'm expecting that you have sutures from me to detect and tell you the site of the tumor actually in quartiles. In case of bigger resection specimen, it's an easy task, for of course. Okay, and number 3, I'm supposed to report the histologic type, and this will be today's scope of the talk, inshallah. Okay, I have to report the histologic grade, whether I'm facing a tumor that is well differentiated, moderately differentiated, undifferentiated, or I cannot determine even. Okay, we comment on the tumor size and the stromal invasion, and I know very well that it's so important to you as oncologists and gynecologists because they are the main things that are affecting the FIGO staging, especially the stage 1 and the stage 2A. We take tumor size in centimeters and depths of invasion in millimeters, actually. In this demo, you can see, do you have a laser pointer here? Okay, no laser pointer, no problem, okay. You can see A represents the depth of invasion or the stromal invasion, which is from the base of the high-grade intraepithelial lesion to the deepest point of tumor invasion. We have B representing the horizontal diameter, and we have C as a third dimension in case you want to know more about the biggest tumor dimension or the biggest tumor size. Okay, what else am I supposed to be commenting on is the status of the lymphovascular invasion. Okay, although this does not affect really the stage, but I know pretty well that it will affect your decision, lymphovascular invasion, and yani, let me know if I'm correct or no, affects the decision of an oncologist. Okay, I have to say if it's positive, I'm seeing it positive, or it's negative, or I cannot determine, because sometimes there are what we call artifact, like retraction artifacts. The tumor is in the middle, and I just cannot determine whether it's really lymphovascular invasion or it's just a retraction due to the processing steps. I believe in this case, I have to tell you that I have I have undetermined lymphovascular invasion, and explain in my report why cannot I be decisive about this and leave the decision for you. Okay. One more thing to comment about is the margin status. The margin status, I have to tell you whether it's involved by invasive cancer or it's free. And if it's free, what's the nearest margin? And is it involved by any in situ lesions or no? Okay. And again, sometimes we face problems like I cannot determine whether margin is affected or no because of extensive cauterization, for example. We can explain this as we have an indeterminate margin status again, and I have to explain to you what's the problem that I'm facing. It's because of a cautery artifact. Okay, getting to more points in this CAP checklist, the regional lymph nodes. And by regional lymph nodes, I surely mean the comment on the pelvic and the para-aortic lymph nodes, okay? I have to tell you whether we have macrometastasis, micrometastasis, or at least isolated single cells invasion. And I have to tell you about the other organ involvement, whether we have an involved vagina and it's for the upper 2/3 or the lower 2/3. Do I have a rectal or a bladder involvement? And I have to mention whether it's in the wall or in the mucosa, okay? And comment on distant metastasis. Most of the time, we don't have the luxury to comment on distant metastasis as pathologists, and we sign out the report as an, if it's a TNM, as an MX, actually, because we don't know. But it's noteworthy to mention that is some sort of controversy in these cases where the WHO considers the distant metastasis as the extrapelvic peritoneum, the bone, the liver, and the really distant sites, whereas the AJCC, which is the American Joint Cancer Committee, also adds the uterine serosa and the adenixa to the distant metastasis. So there's still some debate about this. Okay. And finally, I have to report the stage in terms of the FIGO staging system or the TNM staging system according to American Joint committee, the ninth one, as I know the FIGO stage and the lymph node status are the most important prognostic factors to you as well. And finally, I will comment on the P16 immunostatus, whether it's positive and negative. And now, after covering all these points, actually each and everyone can take a whole lecture to discuss in full details, but our scope today, but our scope today will focus on the histologic type item, okay? This is the proposed classification according to the WHO. As you can see, it's classifying the cervical carcinoma into squamous cell carcinomas, adenocarcinomas, and some others. Squamous cell carcinomas and adenocarcinomas are furtherly classified according to the HPV status into HPV dependent, HPV independent, and non otherwise specified, or NOS as we use the term. NOS is used when we do not have the facility to screen for the HPV. I don't have P16, for example, or I don't have any testing method for the HPV. Okay, now let's see what's the testing methods that are available to detect such a thing. Firstly, we have the HPV molecular testing. That's a test that is done in molecular labs after the gynecologists collected the sample using the cytobrush that is put in the liquid-based cytology containers to be delivered to molecular labs. We test, or they test for them in molecular labs using the PCR or in situ hybridization techniques. Whereas the P16 is a mere immunohistochemical test that is done in regular pathology labs on paraffin blocks. Actually, we stain it and we look at it under the microscope to tell you whether it's positive and negative. Okay, now let's agree on something, that the P16 positivity is considered when I have a block positivity. Block positivity, as you see in the upper photo, means that the tumor is all positive and the stain is obtained in both the nuclei and the cytoplasm. Any patchy or any weak stain is not considered as positive P16 at all. So if I'm gonna define the P16, I would rather refer to as that it's a surrogate marker for the high-risk HPV infection. And by the term surrogate, I mean it's okay to use it instead of any HPV testing, okay? It's with or without the HPV molecular testing that you can determine that the patient is infected with an HPV. Actually, it's a test with a very high sensitivity and specificity that we can rely on. So what else do we use the P16 for as pathologists? Actually, I can use it for other instances to differentiate between high-grade squamous intraepithelial lesion and some benign mimics such as squamous metaplasia, for example. I can use it to differentiate between CIN2 and low-grade SIL. I can use it when there is some disagreement between pathologists. You know, pathology is some sort of a subjective science, and sometimes we have conflicts, okay? So we can refer to the P16 actually to solve the issue. And finally, I can use it when there is a high risk for missed high-grade SIL. Okay, now let's dig deeper and, there's a techno way. Let's dig deeper into further details about subtypes. As I have mentioned, we have the squamous, the adeno, and the others. The squamous cell carcinomas actually constitute the majority of the cervical cancers, and they are furtherly classified into HPV-associated, HPV-independent, and NOS. Again, the HPV-associated constitute the majority of those squamous cell carcinomas, and it has been found that the HPV association is a good sign, where patients with HPV actually have a better overall survival and better free disease survival, whereas most of the cases which are HPV negative or independent were found to be diagnosed at later stages, most probably with lymph node metastasis and shortened or reduced overall survival and disease-free survival. Okay, now these are the variants of squamous cell carcinoma. I just brought this picture. I know that all you can see are just shades of pink and purple, but those are actually to tell you that sometimes it's not so cute and classic, and we can say as simple as that it's a squamous cell carcinoma. Sometimes I need to refer to some further immunohistochemistry, such as the P16, P40, cytokeratin 5/6, to make sure that it's really a squamous cell carcinoma. The non-keratinizing and the basaloid are the most common, but again, I'm emphasizing that things can get mixing up to us, and we see them like those ones, or maybe like those ones. Okay. One more thing to talk about as regards the squamous cell carcinoma. What about the tumor is extending from the cervix to the vagina? Okay. Again, this is a point of controversial, but according to the FIGO, a vaginal lesion involving the external os of the cervix should be considered as a cervical cancer and treated as such. Okay, back again to our subtypes. We're done with the squamous cell carcinoma. Let's go for the adeno. The adeno, again, should be classified according to the HPV status into HPV associated, HPV independent, and NOS, with the HPV associated forming the majority with a better prognosis for sure, as forementioned. Okay, I can furtherly classify the adenocarcinomas into, okay, according to the HPV status and the P16 status into HPV positive and HPV negative. The HPV positive adenocarcinomas include the usual, which is the most common type of which, and the villo-glandular, which we consider as pathologists sometimes as a subtype of the usual, and the mucinous. As for the HPV negative or the P16 negative, we have the gastric, the mesonephric, and the clear. Okay, with the gastric forming 10 to 15%. Okay, now some more details to mention about them. The HPV dependent, again, I'm stressing on the fact that they are the ones with a better prognosis. They say that 77% of the cases have 5-year overall survival rate, with the villo-glandular as the best one with excellent prognosis, and the mucinous with worse prognosis for the HPV positive. As for the HPV negative, we have the gastric with the worst prognosis, and then comes the mesonephric that arises on top of mesonephric remnants in the cervix, and finally the clear which was found to be associated with administration of an old treatment, which is the DIST, diethylstirbosterol. One more subtype we shouldn't forget, although it's rare, is the endometrioid type. Endometrioid type actually are rare tumors. They arise on top of endometriosis in the cervix, but before diagnosing this, I have to exclude that it's metastatic or it's coming as an extension from the uterine course or elsewhere. Okay, again, these are histopathologic microscopic pictures for the subtype. And again, I know that you're not seeing anything but pink and purple shades, but actually we can make a difference. They look to me different. And the problem is not usually that I differentiate between the subtypes. Okay, the echo لو سمحت. الصوت لو سمحت. Okay. But the problem, okay. أقول? Okay. The problem is rather differentiating whether it's really cervical or it's extending from the uterus upwards. Okay. So let's agree on something that usually the primary site is where the dominant mass is there, but this is not the usual story all the time. Sometimes I'm having a mass just in the middle and it's occupying part of the uterus and part of the cervix. So how can I solve this issue? I have the immunohistochemistry. Immunohistochemistry is always the answer to my question. Okay. If you do the P16 in most of the time of the CEA, they can give you positive in endocervical carcinomas. If you do the ER and the PR together with the Vimentin, they give you positive in endometrial carcinomas. PAX8 is another nice stain, but actually it gives positive in both, so don't use it to differentiate between endocervical and endometrial carcinomas. Okay, but it's pretty it's pretty nice to always remember that we have exceptions. There are always exceptions. So let's see this differential, this other differential. As I have just mentioned, I can use the P16 and the ER to differentiate between adenocarcinoma as the usual type, for example, and the endometrial carcinoma. But what about higher grades? What about the serous carcinoma? See with me in this table, the P16, for example, as I've just mentioned, it's block positive. When I have a serous carcinoma and I do the P16, I have a surprise, okay? It becomes P16 block positive again, okay? This is a problem. What am I gonna do? I will go for the ER and the PR. The ER and the PR and the adenocarcinoma of the cervix will surely give me negative, but of the endometrial serous carcinoma, I cannot guarantee that I will always be lucky and have a positive ER and the PR. Okay, for now, how can I solve this problem? Again, the answer to my question is the P53. You can do P53, which is another immunohistochemical marker. You will find it wild type in cervical cancers and mutated in serous high-grade endometrial cancers. Okay. Haven't been through the squamous cell carcinomas and the adenocarcinomas. Now it's time to explore the others. So what are the other tumors that I'm interested to mention? Actually, we have the neuroendocrine tumors, some tumors that are salivary-like, such as the adenoid cystic carcinoma, the mucoepidermoid carcinomas, mixed tumors such as the adenosquamous, the adenosarcoma, the carcinosarcoma, the adenoid basal carcinoma, which is one of the tumors that looks like a basal carcinoma with a good prognosis. We have the germ cell tumors, and finally, undifferentiated or unclassified tumors. This is an entity that we use to describe when I have excluded all the primary possibilities and excluded all the secondary possibilities with immunohistochemistry and all the tools that I can use, and I cannot put my diagnosis in a certain category. Okay, so let's explore the neuroendocrine tumors. As I have learned that it takes you a different decision when you have or you are facing a neuroendocrine tumors in the cervix. Actually, neuroendocrine tumors are classified into low grade and high grade, or we better describe them in pathology into well differentiated and poorly differentiated carcinomas. We use immunohistochemistry such as the synaptophysin, the chromogranin, the cytokeratin 5/6 to make sure it's a neuroendocrine tumor, and we use the Ki-67, the mitosis, to determine the grade. Okay. One more thing that I would love to shed the light on is that we have what we call a MENAN, is the mixed neuroendocrine, non-neuroendocrine tumor. That's one tumor that has more than 30% of the component as neuroendocrine, and another more than 30% that is non-neuroendocrine. For example, adenocarcinomas, and to a lesser extent, squamous cell carcinomas or adenomas. Okay, and it's worthy to mention serous carcinomas. Although there is a general consensus nowadays that most or all serous carcinomas are considered as metastasis or adnexal extension from adnexal or endometrial serous carcinoma, although definite papers or publications are yet for this issue, but this is the general consensus in the application that it's going on nowadays. And finally, one more thing that we have to exclude is that we have, is it really a primary tumor or it's metastatic from elsewhere, okay? Because if you think it's on the breast, you have to do further immunohistochemistry, such as the GATA3-ER, the PR. If you believe it's metastatic from the stomach, you can use the cytokeratin 7 and 20 and MUC2. If you think it's ovarian or from the tubes, another WT1-ER and P53 can help you a lot. The colon, we use the CDX2, the SATB2, the cytokeratin 20. As to the kidneys, the renal carcinomas, we can use the RCC, the CD10. And finally, the bladder, I can help myself with the GATA3, cytokeratin 20, and P63. And coming to the end of my lecture, I'm so happy to have learned that Dr. Nirvana is involved in some sort of presidential initiatives, because I was about to call for this. I was about to ask if anybody of my dear professors and gentlemen is incorporated for this. We need to take the initiative to put the cervical cancer screening and the vaccination. I'm so happy in حضرتك already you took the initiative and you're working on it, because I believe this will save lots of lives and this will save the country a lot of money, okay? If we prevented the cases from the beginning and not had to reach the tertiary level of treatment and surgical interventions. And so, and finally, I would love to thank you all for giving me the chance of sharing in this important and prestigious event. And I would love also to shed the light on the importance of working in multidisciplinary teams, which bring points of views closer and give us a better chance of taking accurate decisions for the treatment and for the diagnosis. Thank you so much. Thank you so much.
Thank you, Dr. Dina, for this prestigious presentation.
Thank you, فندم. تفضل حضرتك. شكرا. على سبيل المثال لما يكون عندنا اوكي اوكي بص انا هقول لحضرتك حاجه هو الكات اوف الموضوع it's variable okay firstly I have to screen السبيسيمن كلها widely and see لو هو فعلا عندي adenocarcinoma with a majority of it with few neuroendocrine features okay people were talking about ان هو الكات اوف should be more than 30% at least ان انا يبقى عندي neuroendocrine differentiation عشان اقول يعني okay لكن it's an important issue I have to extensively sample the specimen لو ال percentage تعدت الرقم ده then I have to consider a neuroendocrine tumor I will definitely go for the immunohistochemistry that I have just mentioned وشوف ال expression بتاعها لو ال two components are actually more than 30% I can consider المينان اللي انا قلت لحضرتك عليها اللي هي mixed neuroendocrine non neuroendocrine يعني عندي مثلا adenocarcinoma اكتر من 30% وعندي neuroendocrine carcinoma اكتر من 30% it's not just neuroendocrine features I have to consider the mean which is the mixed neuroendocrine non-neuroendocrine tumor it's an aggressive I believe ان هو it has a worse prognosis thank you so much اوكي انا هقول لحضرتك هو البي 53 ده المفروض يعني لو الميوت يعني المفروض ان انا اقول ميوتنت لو امتى لو كان في بلوك بوزيتيفيتي او توتال نيجاتيفيتي اوكي انما لو في باتشي بوزيتيفيتي اوكي this is wild type والحقيقه المفروض يعني ريبورت الباثولوجي المظبوط مش بس يقول لحضرتك بوزيتيف او نيجاتيف المفروض يقول لحضرتك this is mutant or this is wild لان هو مش في كل الاميونوهيستوكيميكال ستينز البوزيتيف ميوتنت والنيجاتيف وايلد لا هو I have to interpret ده المظبوط فلكن I'm telling حضرتك يعني إن هو the mutation is in the form of it's either the strong block positivity أكتر من 80% من التيومر واخد أو it's totally negative if you have some scattered cells okay then this is patchy and they consider this as wild type Yes, this is the correct. تمام يا فندم. شكرا لحضرتك.
على بس جوائب يا يوجد نقطة اكسبريشن على سن يعني لو حد ممكن هو فوق او فلوس سوشيال ديفلوبمنت قلنا 40
حاضر طيب انا هقول معلش حضرتك اخر جمله سوري P16 is related okay طب هو ال P16 زي ما قلت لحضرتك it's a surrogate marker for ال HPV testing يعني بمعنى ان انا ممكن استعيض عن ان انا اعمل molecular testing ل HPV and if I have a P16 I can tell that this patient is HPV positive ولكن I still have exceptions يعني مثلا على سبيل المثال السيرس كارسينوما is one of the carcinomas that give me the P16 positive لكن ده لا يعني ان العيان بالضروره عنده HPV infection هو في الحقيقه ال P16 ده بيحصل عشان حصل mutation على molecular level of the P16 and I have the expression بقى is reflected on the immunohistochemistry وده زي ما حضرتك حتى قلت في المحاضره بتاعت حضرتك ده يعني بيفورشيد ال high risk types of the HPV vaccination لكن should be bear in mind at the end of the day this is a mutation يعني ممكن أي حاجة تعملها أي نعم ال HPV is the most common one لكن هو مش بقى 100% من الحاجات اللي هي P16 positive همشي وراها إن هي بالضرورة يكون في HPV infection يعني ولكن what's common is common يعني at the end of the day شكرا لحضرتك Thank you, دكتورة غادة. Merci. Merci.
For this very information about the future diagnosis that we are facing daily with deep communication with you, it will be very beneficial.
My pleasure. Thank you so much, Dr. Gheda. Thank you, everyone. Thank you, brother.
Next speaker will be Dr. Professor Oncology University, and she will address cervical cancer, why it is standard of care
اوكي. لا تمام. مساء الخير على حضراتكم جميعا. Thank you organizing committee for inviting me to discuss what is the actual standard of care in the cervical cancer, the concurrent chemoradiotherapy. The cervical cancer, as all we know, is the fourth most common cancer among the women. In high country or in high developed country, the program are in place which enable the girl to be vaccinated and to get screened regular. Unfortunately, in low and middle income country with a limited resource to preventive measures, we actually face the most of our cases is locally advanced cancer cervix. So the high mortality rate from cervical cancer can be reduced by effective intervention at different stages of life, either at vaccination at young age or as a regular screening of the old age. And this is a summary of the treatment in general for the cancer cervix, starting from the stage 0 up to the stage 4B. And unfortunately, our cases is present inside this table. Most of our patients actually presented with stage 2 up to stage 4B. So the treatment of these cases is actually combined treatment, either surgery followed by adjuvant therapy or definitive chemoradiotherapy. And why my questions now, what is the indication of the concurrent chemoradiation? Is either a definitive treatment in the stage 1B2 up to stage 4A, or as adjuvant treatment after hysterectomy in the cases of high-risk pathological features like positive lymph node, positive parametrium, and positive margin. What is the rationale for the concurrent chemoradiotherapy? Why we give the concurrent chemoradiotherapy? Because the failure rate after the radiotherapy alone is almost 50% in the case of the stage 2B, up to 75% in the stage 3. And the concurrent use of the chemotherapy with the radiotherapy, it appears to be, number one, is addictive effect. It enhances the cell death through the cytotoxic DNA effect. It also synergistic effect. It inhibits the repair of radiation-induced damage, promotes the synchronization of the cells, and limiting the proliferation. And also it has independent effect. And this is the most common used radiosensitizing agent, starting from hydroxyurea, which is the very oldest one, fluorouracil, cisplatin, carboplatin, etoposide, paclitaxel, and we have now new player, which is gemcitabine, capecitabine, targeted therapy, and now it's immunotherapy. So this is a roadmap starting from the introduction of concurrent chemoradiotherapy, starting from 18th and then now up to the 2010. And this is the most common phase 3 trial with concurrent chemoradiotherapy in the stage 1B2 up to stage 4A. And all this trial is including cisplatin as the integral part of the concurrent chemoradiotherapy. And this is the first one, the randomized trial comparing 5-fluorouracil plus cisplatin versus hydroxyurea as a treatment or as definitive treatment in the case of advanced cancer. And all the patients receive external beam followed by brachytherapy. And the results of this trial that we found after 8 years, we have 5-year survival in cisplatin arm was almost 60% compared to 40% in the hydroxyurea arm. And this is another randomized trial against the compare the concurrent cisplatin radiotherapy plus hydroxyurea versus radiotherapy plus chemocisplatin alone versus the radiotherapy plus hydroxyurea and cisplatin plus 5-fluorouracil. And again, there is improvement in the 5-year progression-free and overall survival in the patient receiving the cisplatin as a part of concurrent chemoradiotherapy. And the update of this trial is almost after 10 years of the follow-up. Again, we have the same benefit regarding the progression-free and overall survival. And the starting of thinking, why if I add more of radiotherapy, for example, the patient receives not only pelvic radiotherapy, if I radiate also the para-aortic lymph node. So this R2G trial after 6 years of the follow-up, including the all patient starting from stage 1B up to 2B, is including compare the radiotherapy alone, pelvic and para-aortic lymph node versus radiotherapy plus concurrent cisplatin. And again, there is improvement in the overall survival and disease-free survival when adding the cisplatin or chemotherapy to concurrent radiotherapy. And there is a strong statistical significant difference. We speak about 70% versus 40%. Again, update of this trial, we found that in 2007 there is improvement after almost 100 months of the follow-up. improvement in progression-free and the improvement in the overall survival, editing of the chemotherapy plus the radiotherapy. And this is the most common 5 randomized trial comparing the radiotherapy alone versus concurrent chemoradiotherapy. And upon on these 5 trials, we have now consensus, which is 19.9, that's in the 4-5 major randomized trial, shows a platinum-based chemotherapy given concurrent with the radiotherapy prolongs the survival in the woman with locally advanced cervical cancer, starting from 1B2 up to stage 4A. Again, also the woman with stage 1 and 2A found to have metastatic or positive lymph node, positive parametrial, and positive surgical margin at the time of the surgery. So now it becomes as a backbone that the concurrent chemoradiation is a standard of treatment in the patient with advanced cancer cervix. But this trial resulting this is not identical protocol. In 5 trials, if a trial, for example, uses cisplatin alone, cisplatin with 5-fluorouracil, cisplatin with hydroxyurea, and also we have different inclusion criteria, and this not uniform trial even in the radiotherapy arm. So in the R2G starting to giving us what is called survival meta-analysis. We have 3 common meta-analysis. We have meta-analysis appeared in 2001, and this meta-analysis includes a 17 published randomized trial comparing the radiotherapy alone versus radiotherapy plus the chemotherapy. And again, we have survival benefit regarding the all. We have improvement, absolute improvement in survival up to 12%. Again, we have progression-free survival. We have significant reduction in the local control and systemic recurrence in the case of concurrent chemoradiotherapy. So the conclusion of this meta-analysis, chemoradiation improves the overall survival. We have greater benefit seen in the trial, including the high proportion of patients with stage 1 again and 2. And we have significant improvement in the progression-free survival up to 16% and 12%. But unfortunately, the grade 3 and 4 hematological and gastrointestinal toxicity were common or greater in the patient receiving concurrent chemoradiation. Another meta-analysis, again, this is include almost 8 randomized trial, again compares the chemotherapy alone versus chemotherapy plus cisplatin or 5-fluorouracil, and we have again absolute reduction in risk of death of almost 11%. And another meta-analysis that is published 10 years ago, that's seen the reduction in the reduction in the death rate and the recurrence if the patient receive concurrent chemoradiation. And there is greater benefit regarding the overall survival with the patient have stage 1B and 2A is almost 10%, 7% if the patient have 2B, and 3% if the patient have 3 or 4A. So the 5-year survival is improved by almost 6%. So the comparing the benefit of this meta-analysis either is published 2001 or 2002 or 2010, we have improvement, absolute improvement in progression-free survival ranged from 16% up to 8%, and again we have absolute improvement in the overall survival ranged from 12 up to 6%. Then we go to R2C or ERTC trials that's addressing something new. If the chemotherapy is the main player in the cancer cervix, why not we need to avoid the radiotherapy? In this trial, we question address the role of chemotherapy alone. We give the patient new adjuvant chemotherapy alone, followed by radical hysterectomy, no radiation in this arm, compared to radical chemoradiotherapy. So we have 2 arms, new adjuvant chemotherapy, followed by radical hysterectomy versus definitive chemoradiotherapy. And the primary endpoint was overall survival and the progression-free survival. And to include the all patient, 1B2, 2A more than 4 centimeter, and we have again patient with 2B. In this trial, the results of median follow-up of 8 years, and the patient has underwent if the patient underwent surgery, we have the overall survival of 76%. However, if the patient don't undergo the new adjuvant chemotherapy, for example, here in the rate of pathological complete response, we found the patient after receiving chemotherapy, we have parametrial invasion in almost 20% of the case. We have positive margin still in the 13% of the case, and we have positive lymph node after the new adjuvant chemotherapy in 27% of the case. And 5-year overall survival, as we seen, 72% if the patient received new adjuvant chemotherapy versus 76% if the patient received concurrent chemoradiotherapy. radiotherapy. So the chemotherapy is not the main player here in the cancer cervix. However, the concurrent chemotherapy is a more, give the more overall survival benefits than the new adjuvant followed by the radical surgery. We go now to one of the study come from the developing country, as all the previous study come from developed country, either a GOG trial, which is European trial, or the URTC trial. We found here the concurrent chemoradiation of the cancer cervix, result of multi-institutional study from the developing country, India. In this trial containing more than 7,000 patients, all of these patients have locally advanced cervical cancers. And we found the primary endpoint with overall survival. And we found when comparing concurrent chemoradiotherapy versus the radiotherapy alone, the overall survival is 70% if the patient receiving cisplatin with the radiotherapy versus the 40% if the patient received radiotherapy alone. So adding the chemotherapy not just sensitizing the effect of radiation, but it effect on the 5-year overall survival, 70% versus the 40%. Again, we see here improvement in the overall survival after 8 years. And again, we have another study which is presented as abstract in the last ASCO that compare again in the patient with stage 3B, not only the early stage, but the patient have only stage 3B. We have the patient with FIGO stage 3B, squamous cell, young patient, randomized either to concurrent chemoradiotherapy with the standard cisplatin for 5 cycles versus the definitive radiation alone. And again, we found the adding of the chemotherapy will improve the disease-free survival and will improve the overall survival 50% up to 40% if the patient has stage 3B. So the conclusion of this trial, the addition of cisplatin in the patient with the FIGO stage 3B has improved the both disease-free and overall survival with absolute benefit of 8.5 and 8%. But what about weekly versus tri-weekly cisplatin? They're starting to thinking instead of the giving weekly cisplatin for the patient, we give only 3 weeks. And this is ongoing trial, which is called the TACO trial, which is tri-weekly administration of cisplatin in locally advanced cervical cancer, including the patient from stage 1B2 up to stage 4A, randomized either giving the weekly regimen 40 milligram for 6 cycles versus tri-weekly cisplatin giving only the 3 cycles. And this is actually still ongoing trial. What other radiosensitizing agent? We have another agents like carboplatin. If the patient, for example, have the renal neuropathy or the patients have problem in the cardiac clearance, we can use the carboplatin. And we have paclitaxel. That's, for example, we have phase 2 trials that's comparing using of paclitaxel with carboplatin with concurrent radiotherapy for the patient with stage 1B and 4B. And we have 5-year disease or 3-year disease-free survival, almost 50% for stage 4 and 67% for early stage, and the 3-year survival 89% for early stage and up to 50% in the advanced stage. So we have another player, and instead of cisplatin, if the patient has renal problem or if the patient have another comorbidity, we can use carboplatin and the paclitaxel weekly with with radiotherapy. But this is still only phase 2 trial. We don't have head-to-head comparison cisplatin versus carboplatin. And we have another trial of giving only carboplatin with radiation. This also is a phase 2 trial, non-randomized phase 3. But we have another one, which is a phase 3 trial that randomizes the patient receiving concurrent Gemzar plus cisplatin and radiation therapy, followed by adjuvant Gemzar and cisplatin versus concurrent cisplatin and radiation alone. So this is another form of trial. We have 2 arms of trial. Patient receives his treatment, which is a standard treatment, radiotherapy plus cisplatin, and we have another arm. The patient receives cisplatin plus another chemosensitizer, which is gemcitabine, followed by adjuvant chemotherapy. And this we have arm A and arm 2, and every arm is almost contain 250 patients. And we found here improvement of the 3-year progression-free survival if the patient receive concurrent gemcitabine plus cisplatin versus the concurrent arm alone, and we have improvement in the overall survival. But all arm is still not reaching to the statistical significant benefit. We have improvement, but not much. But again, on opposite arm, we have toxicity. We have grade 2 and the grade 3 toxicity is marked if the patient receive concurrent 2 type of the chemotherapy plus the radiotherapy. So we have more and more combination. So we're starting to adding what is called new what is adjuvant chemotherapy, because the disease progression after radical chemotherapy is still in the more advanced cases is almost 30 up to 40%. And again, we have the problem of distant relapse after patient getting the complete local response to concurrent chemoradiation. So starting of adding what is called adjuvant chemotherapy after chemoradiotherapy. We have another big trial, which is Outbreak trial, which is a phase 3 trial that is published in ASCO 2 years ago. This trial actually compared two arms. We have the backstone arm, which is the concurrent chemoradiation, followed by observation, versus concurrent chemoradiotherapy, followed by adjuvant chemotherapy, which is a carboplatin paclitaxel, and included the all patient, including 1B, 2A, 2B, 3B, up to 4A patients. And also the characteristics is equal between the two arms. We have almost 40% of the patient has the positive lymph node. We have most of the patient has a stage 2B, and again also we have 3B and 2 arm, and both characteristics is equal between the two groups. What is found? There is no improvement, just improvement in progression free, but not reached to the statistical significant difference. So again, the adjuvant chemotherapy after concurrent chemoradiotherapy didn't improve significantly progression free and overall survival. What so the conclusion of this outbreak study doesn't support the addition of adjuvant carboplatin paclitaxel after concurrent chemoradiotherapy with weekly cisplatin. So we have what is called interlace study, and this actually published this year in last ESMO. This is a new idea of adding induction chemotherapy for only 6 weeks, and then followed by the concurrent chemoradiotherapy. And this including the all patient with a cancer cervix, stage 1B2 up to stage 4A, include more than 800 patients. The patient receives the standard arm, concurrent chemoradiotherapy with weekly cisplatin, or patient receive induction weekly carboplatin and paclitaxel for only 6 weeks, followed by concurrent chemoradiotherapy. And the primary endpoint was overall survival and progression-free survival. And then the result was published in ESMO 2023. The patient has markedly and significant improvement in the progression-free survival. The 5-year progression-free survival is 73% versus to 64%. And again, the patient in induction arm has significant improvement in the 5-year overall survival. So now, after almost of 20 or 30 years, we have only, this is only first trial, the second benefit of the induction chemotherapy over the concurrent chemoradiotherapy. So this is the first phase 3 randomized trial in locally advanced cervical cancer shows survival benefit in the over 2 decades. And I think this will change our guideline and the practical guideline in the treatment of the cancer cervix. Also, we have a new players in the cancer cervix, which is immunotherapy. We have Keynote A100. This is a phase 3 trial, including more than 1,000 patients with treatment-naive, high-risk, locally advanced cervical cancer. And this patient randomized either to concurrent chemoradiotherapy, 500 patients, or concurrent chemoradiotherapy, adding the Keytruda or Bimbo in the concurrent setting. And we have median follow-up of 17 months. And the results again of this trial was published last month. The patient has median progression-free survival. It markedly improvement, but it not reached yet to the statistical significant difference. And also we have trended toward improvement the overall survival with adding the Keytruda in the concurrent setting. But however, we have higher grade 3 toxicity in the arm containing the immunotherapy. So the data support the use of the Bimbo plus chemoradiotherapy as a new potential standard of care for patients with newly diagnosed, untreated, high-risk, locally advanced cervical cancer, irrespective of PD-L1 status. So this is all the summary for the treatment or available treatment for the all advanced locally advanced cervical cancer. And the backbone of primary treatment for locally advanced cervical cancer is concurrent chemoradiotherapy with administration of weekly cisplatin with concurrent treatment. However, the outcome of this patient has improved over year, not only because of the chemotherapy, but because of advanced of radiotherapy. We have what is called now image-guided adaptive brachytherapy, which is a major player now in our field, and also have more advanced of the image guided and more conformal external beam and intensity modulated radiotherapy. And this now the future of treatment sequence in the case of advanced cancer cervix. We adding what is called immunotherapy and concurrent chemoradiotherapy. We are starting of thinking the adding the new adjuvant chemotherapy for only just 6 weeks before the concurrent chemoradiotherapy. So this is a vision of is coming from WHO. The vision of WHO that is 2030. It should be more than 90% of the cases should be now of the girl should be fully vaccinated with human papilloma virus, and hopefully this vaccination will eliminate the cervical cancer and so on. Thank you for your attention.
Thank you Ahmed for the wonderful presentation, very updated. فكرت انا كنت مستني الكلام على الكينوت وعلى الانترفيس ترايل، والسؤال ليكي بقى from a limited resources setting. الانترفيس ترايل جابت اوفر اول سرفايفل لطيف جدا باي اديشن اوف كيموثيرابي غلبان عادي بتاعنا،
بالظبط.
والكينوت جابت بروجريشن فري سرفايفل اور اديشن ثيرابي. What would you recommend in our setting? Adding
هو الفكرة احنا
ولا going for PDL testing and going for immunotherapy.
هو الفكره احنا كنا اوريدي بنستخدم ساعات النيو ادجوفانت كجاب قبل الراديو ثيرابي، نظرا ان الماشين بتاعت الراديو ثيرابي والويتنج ليست، فكنا بندي نيو ادجوفانت. بس الخوف كله ان احنا كنا بنخاف ان احنا نعدي الويندو بتاعه الثمان اسابيع او 9 اسابيع بتاع الاوفر اول تريتمنت تايم. الانترليست رايت دي سهلت لنا الموضوع، خليته فقط 6 اسابيع بلس ان انا ادي 5 اسابيع من الكيموثيرابي واحاول ادخل البريك في لاست 2 ويكس، وبالتالي ان انا الاوفر اول تريتمنت تايم ما عدش معايا. فاي ثينك ان هي الانترليست هي اللي هتجوينج دلوقتي وتشينج الجايد لاين اوف تريتمنت I think السنة الجاية يعني.
تمام. سؤال الدكتورة غادة.
Thank you so much for that.
Thank you, غادة.
The population in the two, the interlaced and the
Bimbo.
They raise the low risk patients with more than 50% of more infants. And in contradiction to the other chemo.
Yes, الانترليس.
Also, maybe it needs some function in the two studies.
Yes, I think the trial of Keynote is still immature. We have just a short follow-up. We didn't get the just 17 months of the follow-up. We don't have this follow-up. So we should wait, number one. Second one, there's a patient with the interlist trial, yes, but we don't have actually pathological assessment of this patient. We have just a clinical assessment. This patient didn't undergo, for example, laparoscopic lymph node and to see if this patient have positive lymph node or not.
Thank you so much. Any other questions?
شكرا.
So let's move to our last but not least speaker, my dear colleague and brother, Dr. Khaled Gaballa. He's an assistant professor of surgical oncology, Oncology Center, Mansoura University, and he is partner of all the crimes we are doing in Mansoura. One of the crimes is surgery in advanced cervical cancers. It's a very tough process for any surgeon. It's a hell. لسه امبارح عاملين presentation وعندنا كذا presentation الاسبوع الجاي. فدكتور خالد will speak about residual and recurrent disease in cervical cancer. Surgery can always be an option, but a nightmare for surgeon and for the patient.
Thank you, Dr. Bassel. Good evening, everyone. I'm pleased and honored to be here, and thanks for the council for my invitation. والصوت واضح؟ الصوت واضح صح؟ في الأول ال residual and recurrent disease in cervical cancer surgery can always be an option. هي دي مش إجابة، هو ده سؤال يعني. Can surgery be always an option or not? First of all, primary treatments for cervical cancer have a cure rate of approximately 95% in the early stages and 40 to 60% in the locally advanced disease. The recurrent cervical cancer is defined as the local tumor regrowth or development of the lymph nodal or distant metastasis at least 6 months after the primary lesion has regressed. So the management of the recurrent cervical cancer depends mainly on the previous therapeutic approach the patient had done, the site of the recurrence, the extent of the recurrence, and of course it should be discussed in a multidisciplinary team. The recurrence following primary surgery has been reported in about 27%. Rates following fertility-sparing radical trachelectomy in early stages figure about 4%. Patients who were previously treated with concomitant chemoradiotherapy demonstrated a recurrence rate of about 32%. Typically from 1/3 to 2/3 of the recurrent cases will occur in the first 2 years after the primary treatment. As regards the recurrence modalities, an Italian multi-center retrospective study for about 300 women showed that most of cases of the recurrent cervical cancer were local and regional recurrences. Also, in another trial and assessment of about 560 patients, the most frequent recurrent sites after radical surgery was the central pelvic type. So speaking about the patterns of the recurrence, most frequent sites are the local, central, or pelvic, the regional one, nodal or not. The regional may be anterior, invading the bladder, ureters, or the urethra, posterior, invading the rectum or the anal sphincter, lateral may be invading the pelvic side walls or the vessels of the nerves, or regional involving the pelvic lymph node stations. Distant, including the infradiaphragmatic or supradiaphragmatic nodal recurrence or distant organ metastasis. About 30 to 45% of the cervical cancer recurrences are merely central pelvic type. The central may be in the preserved cervix, as you see in the first photo, or maybe in the parametrium, and the second one, or maybe in the vaginal cuff in the patient who have undergone prior radical hysterectomy. For women who underwent curative intent therapy for cervical cancer, the predominant site of the disease recurrence is local or regional. The risk of persistent or recurrent pelvic disease increases with more advanced initial disease stage. كل ما العامل الأول كان جاي initially more advanced كل ما risk of recurrence طبيعي إن هو هيزيد. The risk of recurrence is associated with well-known prognostic indicators, including the tumor size, the nodal involvement, the tumor histology, the tumor grade, and the presence or absence of the lymphovascular space invasion. A large retrospective trial was conducted by David Shibler recently in 2021. He recruited about 4,000 women with cervical cancer. The rates of recurrence were highest among those with neuroendocrine tumors, the tumors more than 2 to 4 and more than 4 centimeters, patients with more than 3 positive pelvic lymph nodes, patients with lymphovascular space invasions. Among the patients treated for early stage disease, there appears to be no difference in either rate or anatomic distribution of the recurrences in surgically treated patients and patients who underwent surgery followed by radiotherapy. Nearly recurrence rates according to the site nearly واحدة في الاثنين. So a clinical presentation, the patient اللي جاي له recurrent cervical cancer. We are dividing the lecture to 2 parts, the recurrent in the first half and the residual in the second half. So the patient with the recurrent cervical cancer, what will she complain from? Unfortunately, the majority of them, especially the metastatic ones, are asymptomatic. The median time to recurrence ranges from nearly 7 to 36 months. And a systematic review of the literature, 62 to about 90% of cervical cancer recurrences were detected within the first 2 years after the primary treatment. So the patient who had a recurrence, what will she suffer from? Usually she will, if she had a local recurrence, she will have vaginal symptoms like discharge, bleeding, dyspareunia, pain. The patient, of course, we undergo a pelvic examination after the patient come to our institute or to our clinic. A mass or nodularity at the vaginal cuff may be palpated, may be easily prone to bleeding, and may be tender also in the palpation. The next step, usually we must do a biopsy to confirm the presence of the recurrence or not. Women who present with signs like weight loss, abdominal lesions, pain, nausea, or cachexia, who are in favor that the distant metastasis should undergo radiologic imaging to evaluate the metastatic disease. Imaging is essential for women who present with a mass on the pelvic examination because the extent of disease will influence the treatment plan. MRI has shown to be reliable in differentiating recurrence from post-treatment changes in pelvises previously treated for gynecologic tumors. Furthermore, MRI is accurate in evaluation the recurrent tumor extent and organ invasion, which is very beneficial for the planning of the surgery. هل احنا هنحتاج نشيل bladder، هنحتاج نشيل rectum، هنحتاج نشيل حاجة في pelvic side wall. The PET CT scan have also used for evaluation of the recurrent cervical cancer and metastatic disease. It has really relatively a higher sensitivity and specificity in detecting metastatic disease, which lead often to changes in therapeutic plan for women with the recurrent diseases, sparing women from extensive surgical procedures. يعني لو patient هنتحضر for pelvic excenteration usually we do a PET CT scanning لأن طبعا لو عملنا يعني pelvic excenteration وبعديها بفترة بسيطة لقينا في حاجة زي distant mets في اللنج أو حاجة بيبقى موقف مش لطيف يعني. طب ايه المانجمنت بتاع اللوكال ريكورنس؟ لو انا جالي البيشنت examined we did a biopsy we did the MRI examination the PET scan واحنا خلاص متأكدين ان هو just a local recurrence what will you do؟ often طبعا ده متوقف على البيشنت what did he previously do هو عمل ايه قبل كده خد حاجة ولا عمل surgery. For women who present with a local relapse confined to the cervix or vagina treatment the direct to site of the recurrence can be performed with a curative intent. البيشنت who had a hysterectomy or pelvic excenteration سوري البيشنت اللي خد برايور راديشن هيعمل هيستريكتومي او بيلفيك اكسنتريشن والعكس البيشنت اللي خد سيرجري وما خدش راديو ثيرابي ممكن يبنفيت في الحاله دي من الراديو ثيرابي. So the candidates for the surgical resection patients who experience a local recurrence should be offered surgical resection with a curative intent. Commonly employed criteria to identify those women most likely to benefit from the surgery include اللي هم اكتر عيانين ممكن يستفيدوا من السيرجري في حاله اللوكال ريكورنس العيان اللي عنده central pelvic recurrence من غير side wall fixation او associated hydronephrosis patient with long disease free interval tumor size of the recurrence mainly less than 3 cm in diameter. Following the radiotherapy with uterine conservation we usually go for radical hysterectomy or pelvic excenteration for the management of the local recurrence with associated 5-year survival rates ranging between 30 and 40%. However, surgical complications are more common in this setting. In one study, 15 of 34 patients underwent surgery for persistent or recurrent disease following radiotherapy experienced major post-operative complication including fistulas. البيشنت following hysterectomy اللي كان عامل hysterectomy قبل كده undergone hysterectomy with or without adjuvant radiotherapy or chemoradiation pelvic excenteration represents a potentially curative option هو potentially curative لأن pelvic excenteration the patient pays a lot in her quality of life after the operation. Some patients treated with surgical resection for cervical cancer may benefit from intraoperative radiation therapy وده included في NCCN guidelines بس category 3 يعني في major disagreement about ان احنا نديهم الانترابتيف radiotherapy. So as regards the pelvic excenteration, if we'll go to the pelvic excenteration, total excenteration refers to removal of the uterus, tubes, ovaries, parametrium, bladder, rectum, vagina, urethra, and the portion of the elevator muscles. In an anterior excenteration, the rectum is spared. Posterior excenteration, the bladder and urethra are spared. Perineal phase, resecting the anus or urethra, portions من vulva may be needed also in some cases. من الحاجات المهمة قوي إن هو there is no standard excenteration. The choice of the procedure is based upon the location of cancers. Difficulties may arise during surgery. ممكن تبقى داخل في حاجة أنت كنت مقتنع إن هي ممكن تتشال ممكن تلاقيها مش هتتشال في الآخر. Type and location of the previous radiotherapy the patient had before and patient's post-operative goals and expectations from the operation. الانتيريور pelvic excenteration دي صورة بتوضح احنا بنشيل اليوترس والبلادر بنسبير الريكتم posteriorly. Posterior pelvic excenteration العكس we spare the bladder we remove the uterus the cervix the vagina and the rectum. Total pelvic excenteration we remove all يعني تقريبا بنخلي البلفس كله زي الصورة الجاية دي. هنا تقريبا الليفيتور ماسلز باينة تحت مفيش أي حاجة بقى في البلفس لا يوترس ولا بلادر ولا ريكتم ولا أي حاجة خالص. most يعني اكتر ثمن تقريبا العام بيدفعه هو الاستوماس. بيشنت هيطلع mainly bilateral permanent في most الحالات permanent stomas واحده urinary وواحده fecal. systematic review كان معمول من مايكل هوكل included 21 studies for pelvic excenteration for gynecologic malignancies عموما مش recurrent cervical cancer بس. ولأن 1/3 of the patients were found to have unresectable extrapelvic disease found at the exploration بعد ما فتحوا البيشنت. عشان كده دايما احنا في قرار الاكسنتريشن ده بنبقى يعني ايه ماسكين ايدينا الى حد كبير قوي ما بنتسرعش فيه خالص وبنجهد نفسنا قوي في الانفستيجيشنز بالذات radiological imaging يعني. Resection with clear margins were received in the patients اللي هم قدر يكمل فيهم من حوالي 75 ل 90% منهم. Operative mortality reached about 5%. Those who successfully underwent the surgery حوالي 50% ممكن يبقوا have a chance of being cured. Although the number of the patients who had cured by excentric surgery is small, the surgery is still an opportunity for survival when faced with certain risks. We had a retrospective review also of some of our patients under aortic centration at our institute from 2011-2018. Surgical outcome was analyzed according to modified Clavien-Dado classification. Overall survival was defined as the time from the accentration date to the of this or to the this or the last contact. Survival analysis was performed using the Kaplan-Meier method. Our results, احنا كان عندنا 23 patients underwent total pelvic accentration. All the patients had received the prior treatment, surgery, radiotherapy or chemotherapy. Urinary diversion technique اللي كان مستخدم في كل البيشنتس كان إليا لوب كونتوي. Permanent colostomy was performed in 11 cases of pelvic accentration, 10 temporary diversion, 7 of them was never reversed again. دي صور لحالات من حالاتنا. الصور دي كنت واخدها من الدكتور باسل حقيقة يعني. As regards the mortality in our patients, no patient had an intraoperative mortality. However, two cases passed away in day 0 without extubation. The 30 days mortality, one case passed away prior to discharge from severe chest infection. One case discharged and admitted in ICU with pulmonary embolism. So we had a mortality rate of about 17%, which is a little bit high. As regards the morbidity, we had hemorrhage, leakage, wound infection, thrombovenous embolism, and chest infection in a number of cases. For the sake of time, I will just. So as regards the survival, the 2 years disease-free survival of the pelvic accentration, our patients was 39%. The 5 years disease-free survival was 8.6%. The 5-year overall survival was 17.3%. We had also unexplained result in about 5 cases of our patients that had a massive recurrence dissemination after the pelvic accentration. Although pre-operatively ما كانش فيه أي signs للميتاسيس في الراديولوجي اللي كنا عاملينه، بس after the operation within يعني few months the patient had a disseminated disease. Our conclusion that despite being a feasible procedure with accepted morbidity and mortality for such a challenging technique, survival outcomes have not significantly improved despite improvement in technique and patient selection. Multiple non-modifiable factors at the time of the accentration are associated with the poor survival. We can search for alternatives زي ما قلنا مثلا في المحاضرة اللي فاتت عن الimmunotherapy أو alternative therapy في recurrent cases. NCCN guidelines لسه up till now في patient prior radiated with local regional recurrence they recommend doing the excentrations. Patients with azuritic metastatic disease أنا ممكن أفوت الحتة دي بسرعة شوية عشان الوقت عشان لسه أكتر من نص المحاضرة. البيشنت اللي فيهم azuritic metastatic disease أهم نقطة فيهم إن هم برضو just must be biopsied عشان في بعض الكيسز مذكورين في الليتريتشر كان في زي second primary يعني بعد ما البيشنت عمل ميتاستاتيكتومي mainly pulmonary ميتاستاتيكتومي طلع اللي في اللنج ده كان أصلا primary ثاني. So about the residual cervical cancer for the patients who had received the prior concurrent chemoradiotherapy, the exclusive chemoradiation represents a standard treatment for locally advanced cervical cancer as well known. The chemoradiation followed by radical surgery may play a role for the patients with suboptimal response or in low-income countries with limited access to the radiotherapy. زي ما موجود عندنا في مصر بالظبط. المشكلة اللي بتواجهنا كلنا ان احنا مش كل البيشنتس بيقدروا يروحوا ياخدوا البراكيوثيرابي. البراكيوثيرابي مش متوفر في كل حتة. بيجي لنا بيشنتس كتير بعد ما خلصت الكيمو الاكسترنال بيم عايزة تروح تاخد البراكيوثيرابي مش قادرة تروح لأي أسباب بقى ان هو عيانة من مكان هتسافر لمكان تاني. فالبيشنت ده هل هنقدر يعني نوفر فهم الهيستريكتومي؟ هل الهيستريكتومي في الحالة دي هتفرق هتفيد في السرفايفل؟ In recent decades, adoption of radical surgery as an alternative to intracavitary brachytherapy after chemoradiation has been proposed to improve local disease control and to reduce both radiation dose and potential toxicity. As of Roma 2 trials, which was done in Gemelli Hospital, I was there and that period, كانوا بيدوا patients, mostly young patients, external beam radiotherapy مع concurrent chemotherapy وبعد كده بيعملوا لهم هيستريكتومي. ما كانوش بيديهم فاجينال براكيوثيرابي. مينلي كانوا بيقولوا عشان يعني اللوكال افكت بتاع الفاجينال براكيوثيرابي على البيشنتس دول بالذات ان هم يانج وسكشوال اكتف فكانوا بيحاولوا ما يديهمش براكيوثيرابي. لقوا ان في باثولوجي كومبليت ريسبونس ريت في حوالي 50% من الحالات اللي اتعمل لها هيستريكتومي افتر وكان في 3 year local regional failure about 7% بس. في other two prospective randomized studies حاولت تجاوب عن السؤال هل في survival benefit ان احنا نعمل radical hysterectomy بعد ما ندي concurrent chemoradiotherapy في البيشنتس دول. للاسف الاجابه ما حدش لسه عارف يوصل لها لغايه دلوقتي. we failed to demonstrate a survival advantage until now. بس يبقى برضو السؤال اللي هو يعني despite the lack of high quality evidences of survival advantages for patient managed by exclusive chemoradiotherapy versus chemoradiotherapy plus radical surgery السنترز اللي فيها shortage of intercavitary brachytherapy زي عندنا في مصر ان احنا ما زال عندنا shortage في intercavitary brachytherapy فاحنا لغايه دلوقتي برضو مش عارفين نجاوب على السؤال ده هل البيشنتس دول هيستفيدوا فعلا ان هم يعملوا راديكال hysterectomy افتر هل ده هيفرق في السرفايفل فعلا ولا لا ده اللي هنشوفه في بعض الترايز القادمه completion surgery after chemoradiotherapy provides the most relevant prognostic parameter ده for sure لان هو انا هشيل المكان التيومر اللي هو radiated وهقدر احلله باثولوجيكالي كويس هقدر اعرف فيه ريزيديو ولا لا بس هل ده يفرق في السرفايفل or not we don't know yet indeed absence of residual disease has been associated with the better outcomes in the term of the disease free survival a study conducted by Philip Morris regarding about 135 patients كانوا اخذوا كيمو راديشن ثيرابي قبل كده followed by pelvic surgery. The survival of the patients was correlated with the presence and size of the residual disease and the presence of the nodal involvement. بعد ستري سرفايفل في الكيسز دي الحالات اللي ما كانش فيها اي ريزيديوال بعد concurrent chemoradiotherapy كان 93% اللي كان فيها ريزيديوال اقل من 1 سنتيمتر كان 75% اللي كان فيها ريزيديوال اكتر من 1 سنتيمتر كان 35%. So the completion surgery after the chemoradiation has a place in multimodality measurement but further investigations are needed to analyze the real impact of such surgery on the survival of the patients. Another study was conducted by Anik Boyers. Anik Boyers هو اللي عمله ان هو الحالات اللي خدت كيمو راديو ثيرابي عمل لها قسمهم نصين في بارت عمل زي simple hysterectomies وبارت عمل radical hysterectomies افتر وقارن هل ده هيفرق في السرفايفل في حاجه لا برضه في النهايه ان more radical surgery was not associated with improved disease free specific free survival but did result in significantly more severe morbidity. Another Japanese trial was also conducted for hysterectomy after the concurrent definitive chemoradiotherapy. They found that برضو the presence of the residual disease هو كان أكتر حاجة تأثر على السرفايفل لكن وجود السيرجري أو not هل هيفرق في السرفايفل not so sure. هو قسمهم لثلاث حاجات EF1 الإفكت 1 إفكت 2 و إفكت 3. الإفكت 1 ده اللي هو كان في أكتر من تلت الخلايا الكانسر لسه بريزنت في السبيسمن اللي اتشالت 2 or 3 واحدة أقل من التلت واحدة ما فيهاش خالص باقي حاجة. طبعا كان في survival benefit و disease free survival benefit واضحة ما بين ال EF1 وال EF2 و 3. Another trial was a retrospective study, multi-center study from Gemelli Group. برضو الحالات اللي خدت concurrent chemoradiotherapy اتعمل لها كلها بعديها hysterectomies. وقارنوا survival between الحالات دي. الحالات اللي كان فيها pathological complete response of course had a much more overall survival than the cases that had the microscopic disease or residual macroscopic disease. But still the most important question, would the surgery add the benefit for the survival or not, was not answered. ده systematic review Dutch systematic review معمول من حوالي سنتين على عدد كبير من الستاديز. في الآخر بعد ما عملوا exclusion criteria 6 studies were included حاولوا برضو يجاوبوا على نفس السؤال. 170 patients were treated with a salvage surgery. 131 patients mainly treatment with salvage surgery based on biopsy positive results. 72% ل 100% showed residual disease on surgery specimens. 44 patients treated with salvage surgery based on the suspected residual disease on the radiology. They found an overall survival rate after salvage surgery was 69%. They confirmed that you have to confirm residual disease by biopsy before performing salvage surgery عشان في نسبة مش قليلة من البيشنتس اللي بتعمل salvage surgery after proving disease by the radiology was negative. يعني الحالة في الراديولوجي بتبان ان هي فيها residual disease وبعد ما بتشيل بيطلع ان ما فيهاش. اوكي بس انا قربت اخلص خالص. اخر حاجه بس حبيت اتكلم عنها بسرعه في اخر 2 سلايد the Egyptian residual cervical cancer. حاجه غريبه شويه بنشوفها مش موجوده في اي الجايد لاينز ومش موجوده في اي حاجه. subtotal hysterectomies in cervical cancer which I call the tumor sparing surgeries. طبعا دي كلمه مش مكتوبه في الليتريتشر يعني دي الكلمه بتاعتي انا ان حاله بتبقى مثلا stage 2B حاله stage 3A حاله stage 2A2 تروح لحد يشوفها فيقول لها احنا we can go for surgery first. فيدخل يشيل ما يعرفش يشيل فيقوم شايل اليوترس الفندس والتيوبس يشيل الجزء النورمال ويسيب التيومر تحت which is really a tumor sparing surgery. بعد كده بقى بيبعت لنا الحاله نحاول نتعامل معاها. المشكله هنا ان الكيسز دي طبعا بتبقى individualized decisions. احنا ما عندناش اي يعني ريفرنس او حاجه في الليتريشن نرجع لها. مش هتلاقي حد بيتكلم ان حاله عندها سيرفايكال كانسر دخلت شالت اليوترس من غير السيرفكس، هتعمل ايه بقى في السيرفكس اللي باقي؟ يعني الكلام ده صعب شويه نلاقي جواب عليه. We had a problem في application of intracavitary brachytherapy for such cases. خلاص احنا مش هنعرف ندي الحاله brachytherapy، مش هنعرف نحط الابليكيتور، هو الراجل ظبطنا يعني. Usually managed by external beam and the chemo and concurrent chemotherapy. I would encourage collecting data of such cases from all over Egypt to provide an algorithm for their treatment. لأن يعني الحالات دي مثالي مش موجود عنها أي كلام في الليتريتشر، لو نقدر احنا نجمعها ونعمل عنها حاجة هيبقى شيء فعلا very beneficial يعني. Just to conclude, surgery can be an option for selected cases of the recurrent cervical cancers. The patient with suspected recurrence should undergo a biopsy. أي حالة فيها recurrence لازم تكون biopsied الأول. In addition, imaging is essential for women who present with a mass on pelvic examination because the extent of disease will influence the treatment plan. هنعمل excentrition ولا لا، هنشيل bladder ولا لا، anterior or posterior. mainly احنا أي حالة بتدخل تعمل excentrition لازم تكون consented على anterior and posterior pelvic excentrition طبعا. بس anyhow احنا بنحاول نتكلم، احنا نقول احنا غالبا ان شاء الله البلادر مش هتتشال او الريكتوم مش هيتشال، لكن لازم الحالة تبقى عارفة ان احنا whatever يعني اللي هنقابله هنحاول ايه نتصرف معاه. Compression surgery after chemoradiotherapy can be offered to patients with residual disease, especially when there is a lack of the resources. زي ما بنتكلم على ان في لاك في البراكيثيرابي في حالات كتيره من اللي بتجيلنا. While the benefit in terms of survival is always controversial, compression surgery aids to the local control of disease and disease recurrence. ان هو ممكن يقلل فقط الديزيز recurrence، لكن ما عندناش اجابه واضحه على overall survival. We should increase the awareness about proper workup in cervical cancer patients to limit the unaccepted approaches like subtotal hysterectomy في حالات cervical cancer. واسف ان انا طولت عليكم.
Thank you بروفيسور خالد. يعني for the finish of this session cervical cancer اللوكالي ادفانسد بالذات من الحاجات اللي احنا يعني واضح فيها جدا اثر المالتي ديسيبلينري مانجمنت بتاعتها. من الحاجات اللي لازم تتعالج مالتي ديسيبلينري، ان الجراح لوحده ما ينفعش ياخد قرار ولا الكيموراديوثيرابي لوحده ياخد قرار. الحالات كتير جدا يا دكتور حلمي بنشوفها عامله جراحه even not subtotal even يقول لك انا عامل راديكال هيستريكتومي وعامل فيرتايم وتلاقي بوزيتيف مارجنز وبوزيتيف بارامتريوم and then you refer. اللي بيحصل الحالات دي بعد كده ان هي بتاخد الهدف الاساسي بتاعنا، الهدف الاساسي ان احنا ودكتوره نعمات ما نجتمعش مع بعض الا ان هي تدينا حاجات ادجفنت بس. يا اما الحاله تعمل جراحه وتاخد شويه ادجفنت اكسترنال بيم او كده، او ان هي تاخد ديفينيتيف كيمو راديوثيرابي من الاساس. انما جمع الجراحه مع راديشن من واحد يعني لسه عامل امبارح بلفيك سنتريشن، عندي يوم الاحد بلفيك سنتريشن وعندي الاربع جاي بلفيك سنتريشن موستلي علشان الكواليتي اوف لايف، لان الحالات بقت كلوكه ريكتو فازايكل على فاجينا فازايكل فيستولا كلها مفتوحه على بعضها. الحالات دي بقى لي شهور يعني هي رافضه الاكسنتريشن وانا مش متشجع اعملها لها، بس خلاص انكومباتبل كواليتي اوف لايف. تعمل جراحه بوزيتيف مارجنز بوزيتيف بارامتريوم، تاخد irradiation غصب عنهم لازم يديهم irradiation، فتحت البلادر على الريكتم على الفاجينال ستامب، الحاله تخش بعد شويه هنركب بي سي ان، شلنا البي سي ان، لا انا ما عنديش كونتيننس خالص لليورين، ما عنديش كونتيننس للستول. الحاله امبارح اللي احنا عاملينها كانت توتالي خلاص اوبستراكتد، يعني ما رضاش تعمل اكسنتريشن، اللي بعد ما بقى توتالي اوبستراكتد فشلنا الريكتم بالبلادر بتاع خلينا توتال اكسنتريشن تماما للبلفس. ولا الدكتور بيبقى فرحان وسعيد ولا العيان بيبقى فرحان وسعيد، بس الكواليتي اوف لايف بيبقى احسن من الكلوكه المفتوحه على بعضها او مع السيفير بين بتاع الريكارنس ده وكده. فالسيرفيكال كانسر بالذات لازم تو بي مانجد بالذات لوكالي ادفانسد ان مالتي ديسيبلينري تيم، ولازم يعني يبقى في مسج قويه جدا للجنرال سيرجيكال اونكولوجيست والجنرال جاينيكولوجيست ان هم بقدر الامكان ما يحاولش يمد ايده في حالات السيرفيكال كانسر الا بعد ام دي تي ديسيجن. دكتور حلمي اتفضل يا باشا.
برضو عايز اضيف بالنسبه للهيستريكتومي، وطبعا ذا بيست كيس سيناريو التوتال هيستريكتومي، حتى لو بعمل هيستريكتومي لحاجه بناين، ان البلادر فانكشن السكشوال فانكشن والريكتال فانكشن ماتش بيتر بعد التوتال هيستريكتومي مش السب توتال هيستريكتومي. في كتير من الدكاتره بيقنعوا الستات ان السيرفكس ده مهم قوي للسكشوال فانكشنز which is not true at all اطلاقا. يعني لو الست مصره انها تعمل سب توتال هيستريكتومي يبقى لازم تعمل قبل السب توتال هيستريكتومي تعمل باب سمير تكسكلود ان هي ما عندهاش سي اي ان او ما عندهاش اي كارسينوما انسايتو. بنشوف ناس بتعمل زي ما حضرتك قلت سب توتال هيستريكتومي على كانسر سيرفكس، هو اكشولي ما فحصش العيانه وما مدش ايده في العيانه.
والله احنا في كيس شفناها كانت عامله راديولوجي بري وباين انها لوكال ادفانسد والراديولوجي عليه اسم الدكتور ودخلها العمليات برضه وعملها.
دكتور حلمي انا عندي حاله
يعني
3A وكتبت لها ورقه رسميه، رحت لفلان وفلان وقالوا لي هنعمل عمليه، كتبت لها ورقه كده وختمتها ان دي 3A وتروحي تاخدي كيمو راديو ثيرابي كذا كذا، وقلت لها حتى روحي للدكتوره نعمات وبلاش جراحه. يعني الكلام ده كان يوم الاحد، يوم الجمعه انا داخل المستشفى لقيتها بتعمل الجراحه في مستشفى خاصه. يعني
ان هو دايما العيان طبعا لما بيسمع كلمه جراحه بتبقى بالنسبه له تقول لك هشيل التيومر، غير ما تقول لها روح خدي اشعاع خدي كذا، لا ده انا هيدخل هيسيب بوزيتيف مارجن، انتفى الغرض من يبقى خد السايد افكتس بتاع التو موداليتيز، سيرجري وفي نفس الوقت راديو ثيرابي.
وبالظبط زي ما حضرتك بتقول البيشنتس دايما بيفكروا بدماغه ان هو يعني
طبعاً.
ايه يعني هاخد كيمو راديو ثيرابي ومش هتشيل الورم، ازاي مش هتشيله؟ يعني هفضل عايشه والورم لسه موجود مهما تحاول تكسبلين هو الكيمو راديو
نرجع
ثيرابي
بقى نقول
هيموت التيومر.
الاديوكيشن بتاع العيانين والحاجات، لازم العيان يبقى فاهم وفاهم وفاهم، والحاجات دي طبعا مهمه جدا. شكرا جزيلا على النايس برزنتيشن بتاعتك.
We close the session now. Any other questions? So thank you, Dr. Ahmed.